Nice.
The Joint Experience and Local Mental Health System Model, AISME October Florence. The Joint Experience and Local Mental Health System Models derives from our long-term work in Florence and Prato, in collaboration with international organizations as Mental Health Europe and the European Network of Users and Survivors of Psychiatry. The participants are user and relative groups or associations, service, professional and local governments committed both to the deinstitutionalization processes and to holistic approaches. The psychiatric hospital, the closure of the psychiatric hospitals in Italy, Law 180, 1978, came out of a wider social movement fighting for fundamental human rights for all. The evidence of illness that resulted from both institutionalization and over-medicalization contributed to facilitate the radical change in mental health services and stimulated alternatives to all medical approaches. The dominance of the medical model. Nowadays, despite a reduction in hospital-based treatments, there is an even bigger trend to over-medicalize psychological distress and ignore psychosocial interventions. On the other hand, the so-called territorial integrated health social treatments are often dominated by the medical model, while the other models appear lateral and subordinated. The care plans are too much centered on the illness and not enough on the psychosocial dimension. The result is that users are pushed in the direction of medical treatments without any other choice. The Prato experience in Prato for a period of about 20 years, thanks to special links with the national and international organizations. Many self-help oriented groups and mental health associations have been developed through collaboration between mental health services and civil society. Hence, many collaborative projects and new relationships between professional users and ordinary citizens have been produced, the so-called joint experience. The involvement of all actors. The main strategic element in this model is the direct involvement of ordinary citizens and of their representative in the construction of the joint experience. In this way, it is easier for people to escape from therapeutic rehabilitative situation when evidently dysfunctional. On the other hand, the joint experience gives confidence to people in very bad situation at risk of abandonment to ask for support. The intermediate area of the joint experience, the establishment of an autonomous area of the joint experience is foreseen. This area, which has an intermediate position between the services and the communities, is jointly coordinated by users and relative associations, by service and by local governments. Participation in a joint experience is totally independent from the diagnosis made by the service because it has to do with personal and local dimension. New changes of choice. The model is not prejudiced against the therapeutic rehabilitative model of service. It claims instead the creation of new intersectorial pathways independent from therapeutic rehabilitative diagnosis. In these ways, it is possible to meet needs and aspirations of those who wish to be active in their own recovery and supported by people they have chosen. Autonomy and collaboration. The intermediate area of the joint experience, autonomous but in close relationship with service and local government is also a precious element for supporting the democratic development of the whole local mental health system. Data from the Prato experience suggest that the joint experience project improves the quality of people lives and reduces the need for expensive rehabilitative facilities. Joint experience and local mental health system schemes. The first schemes adopted in 2001 gives evidence to the intermediate area of the joint experience between the area of the service and the area of the community. The three areas altogether compose the local mental health system. The second scheme, more recently adopted, gives evidence to some indicator which allow to evaluate how the whole local mental health system is working. The local mental health system scheme. Local mental health system scheme with indicators. Consideration on the joint elements and local mental health systems model. The existence of joint element within the community is not only a technical matter related to service. Consideration on the joint experience and local mental health system model. The existence of joint experience within the community is not only a technical matter related to service, but also a political matter which involves the whole community. This means that also the local governments have to be closely involved. A local mental health system oriented towards a joint experience will support their development also by activating a special area intermediate between the service and the local governments. This intermediate area may consist in a permanent intersectoral board or in a proper organization, autonomous from both the service and the community, but at the same time very close to them. Agreements between service, local governments and association will be necessary to allow adequate space to joint experience. It will be important that the joint experience are placed out of the service, otherwise dependence will be inevitable produce. Allow users to express their own project, avoiding to pressure them with the project and the expectation of service and of other institutions. Provide adequate articulation between users and carer groups whose needs are often different. Organize a network between users and carer groups. Give peer collaboration and not benevolent support. Joint experience look for collaboration, but also for autonomy. They are a human capital. Integrate the global knowledge of service experts by professional with the local knowledge of user experts by experience. It has to be avoided to hide behind user and carers institutional conflicts inside the service or between services and local institutions. This is one of the reasons why it can be useful to establish the intermediate area as a proper and autonomous organization. The joint experience needs to be visible in local, regional, national and international mental health records. Data need to be collected accurately and permanently with the ordinary involvement of users and carers. Use evaluation tools agreed by all the subjects involved in each community as the community asset mapping to mobilize at best all the existing resources and talents, user and relative groups, association included. It has to be clear the difference between the boards of association we have a consultative status within the service or other organization, and the coordination of the joint experience which has to be done jointly by service, association and